Okay, so I'm going to get started. I'm Jeff Jacobs. I'm the moderator for today's sessions. Welcome to Marcom 2025 in conjunction with Metro DC. Um, this is our virtual portion. Well, we have a hybrid on Saturday and then half day Sunday. So I hope you guys enjoy everything. I wanted to introduce Dr. Clarke Darlington. He is the National Medical Director of Occupational Health at Premise Health. He's been with Premise in some form since January of 1988. And I met Clarke probably about 15 years ago. He was giving one of his ACMED introductory courses, and he gave uh, a similar presentation on reviewing audiograms. And I've always found audiograms very challenging, and he simplified things so
How are
much.
they challenging?
Yeah, well, yeah. So I think you're going to really enjoy and appreciate Clark's presentation. We'll hold questions until the end. And if you have a question, just put it in the chat and we'll get to it in order. So, Clark, thank you for speaking to us, and the floor is yours.
Okay. Thank you very much, Jeff. Can you hear me all right?
Perfect.
Okay, very good. Well, thank you so much for inviting me, Jeff and Keith. Today, I wanted to really focus on three questions or three issues. One of those is that, well, there's many causes of hearing loss. So how do you know your employee has noise-induced hearing loss as opposed to otosclerosis or a tumor or some other medical cause or disease? Number two, if it is noise-induced hearing loss, how do you know it's work-related? And if it is work-related noise-induced hearing loss, then what are our reporting obligations to OSHA? Following discussing those issues, I want to talk a little bit about some of the controversies in this field, some of the new technology that's being used, and of course the hot issue being ototoxicity from solvents and from things in the plant besides noise. And then if we get time at the end, which I think we will, review some cases that are illustrative. So I'm going to start with, our sites across the nation review hundreds and thousands of audiograms. And one of the questions has always been, who do we refer? When do we refer these cases? And who do we refer to? We can't send thousands of cases to local community ENTs. We can't send thousands of cases to local audiologists. So who do you refer and when? Well, as a business, we generally don't refer noise-induced hearing loss if it's classic, not that severe. Unless the person's going to retire and file a workers' comp claim, then we probably would. But generally, garden variety noise-induced hearing loss, we generally don't refer. ENT can't really add much to them other than, oh, well, I can't fix it in the operating room. Not much for me to do with this. Why'd you send this case to me? Presbycusis, same thing. Don't send that. Everybody gets old hearing as they get older, so don't send many of those. We also don't send people that we can fix in the clinic. If we can clean out their ears, they got wax in their ears, cerumen impaction, we do that. They have otitis media, we'll treat that. Otitis externa, we'll treat it, and then we'll repeat the audiogram. And if it's significantly improved, we will take it from there. The kind of cases we refer to out are cases that we don't know what the cause is, or we suspect we know what the cause is, and it doesn't look like anything that's within our domain to treat, like sudden sensory narrow hearing loss, or otosclerosis, or cholesteatoma, or a possible tumor, or Meniere's disease. Those are the kind of cases we generally refer out. Now, just to start with the anatomy, of course, our hearing tests are, of course, just air conduction for the most part, unless we start working up the patient. But gee, it's only measuring what the ear can hear. And you can see that it's divided into two sections. One is the conductive part that takes the waves through the canal, the tympanic membrane, through the ossicles to the footplace, the stapes. So there's no hearing going on there. It's all conduction and amplification. So that's why it's called conductive. And then we have the sensory neural part, which is the cochlea and the eighth nerve, the hearing organ and the eighth nerve. Now, oftentimes we want to localize the problem in the workup of the patient. And this is what ENT does, and audiologists do. So we'll order a complete bone and air audiogram. What's a bone audiogram? What is that? Well, a complete audiogram, or bone and air audiogram, in addition to the air conduction, is measuring the sound presented to the mastoid, or the bone, the skull. So it bypasses the conductive part here, bypasses all of it, and it just measures what the cochlea and eighth nerve can hear. So why would anybody do that? Because it localizes where the problem is. Okay? So if both bone and air conduction are low, where's the problem? It's in the cochlea, right? Or the eighth nerve. Doesn't matter how you present it through the bone or through the air. If it doesn't hear it, right, it's sensory neural. But on the other hand, what if bone conduction is normal? Bone conduction is normal. That means the cochlea is hearing just fine. And the air conduction, if it's low, abnormal, localizes you to someplace in the conductive part of hearing. Someplace in the canal, the drum, the ossicles. So that's called a bone air gap. Bone air gap means bone conduction is normal, air conduction is low or abnormal. Okay, we're going to see some examples of that as we look at audiograms going forward. All right, let's go on to the next slide. And this, of course, is the organ of Corti. And you can see the hair cells there connected to the eighth nerve. You have inner hair cells and the outer hair cells. Now, when you destroy your hair cells from too much noise, you generally damage the outer hair cells, not the inner hair cells. And they're much more protective. That's why you don't go totally deaf from noise exposure, because the inner hair cells are relatively protected, even though the outer hair cells are damaged. Now, this is a picture of the cochlea, and you can see all the hair cells. You can see that where the sound comes in the cochlea is the highest frequency, 8,000. Okay, and then you can see around the curve there, it's like rounding the curve on a stock car race. Whammo! You hit the wall on the curve at 4,000, where the notch is. We see on these audiograms. And then the lower pitch sounds are relatively protected because they're way inside the cochlea. So, why is noise-induced hearing loss high frequency? Right here. It's because the high frequency hair cells in the beginning of the cochlea are hammered the most with the sound. And this is a picture of a chinchilla cochlea that's not exposed to loud noise. And you can see all the hair cells look intact. And you can see, yep. Okay, now here is a chinchilla cochlea that is exposed to loud noise. Now what happened? Wow, look at that. 4,000 high frequency loss of hair cells. Okay. So, okay. That's what it looks like on an audiogram. It's high frequency, not low frequency, not mid frequency. It's high frequency. And it's bilateral. Okay. Because hardly anybody just puts a plug in on one ear. You either wear them or you don't, both ears. So you get this notchy pattern that may center around 4,000 or 6,000, usually 4,000 or close to that, and then has this recovery at 8,000. Okay? So noise-induced hearing loss, high-frequency hearing loss. Remember, your speech frequencies are 500, 1,000, 2,000, 3,000. There's no loss here. 0 to 25 is normal. No loss there, but starting to be some loss in a notch pattern at 4,000 early on, both ears, with recovery at 8,000. Okay. Now, remember we said two kinds of hearing loss. Most common hearing loss, type of hearing loss actually is sensory neural. Why? People are exposed to a lot of noise and they get older. So we got lots of presbycusis and lots of noise-induced hearing loss, which may be occupational or may be recreational. Conductive hearing loss, of course, could be things like earwax, having a cold, eustachian tube dysfunction, and that is actually the second most likely cause, common cause of hearing loss. Okay, as the noise-induced hearing loss gets more severe, the high-frequency loss gets more severe. And you can see this notchy pattern that's bilateral with now a little bit less recovery. Okay, same pattern, bilateral. And again, there's the cochlea that shows the correlation there anatomically or pathologically. Okay. Now, here we have unilateral hearing loss. Okay. And we have a flat pattern. Okay. So now on the left side, we have pretty normal hearing. But on the right side, we have another pattern. Does that look like noise-induced hearing loss? No, it does not. Now, we can't tell if this is conductive for sure without a bone and air study, but high likelihood that this is conductive because many causes of conductive hearing loss are a flat pattern involving mid and low frequencies as well. Okay. So what could this be? Could be wax in the ears. Could be ossicular chain disruption. Could be otosclerosis with fixation of foot plate of stapes. Could be anything in that probably conductive area. Again, we'd have to do a bone and air study to verify that it did indeed be a bone air gap. But in general, flat patterns tend to be conductive. Okay. Now, conductive hearing loss. Somewhere there's a problem in the outer middle ear. Now, when you see something that looks like conductive hearing loss, you absolutely want to look in the ear. Why? Because there's a very good chance you're going to see something wrong. You can't see noise-induced hearing loss. The ear exam is normal. You can't see an acoustic neuronoma. It's too deep. You can't see otosclerosis. But most causes of conductive hearing loss, you can see something wrong. Hole in the drum, something like that. People generally complain their ears feel stuffy, and then when they talk, it echoes. Conductive losses are often flat and have low frequency hearing loss. Most conductive losses can be treated with medical treatment. Not so with noise-induced hearing loss. Not so with presbycusis. Okay. So, causes. External air causes, impacted cerumen, very common, probably the most common. Otitis externa, not so common, but hereditary deformities like exostoses. Middle ear problems, otitis media, perforated TM, cholesteatoma, otosclerosis. So we're going to cover these conditions. So most conductive hearing loss, almost all those things, you can see with your otoscope. Other than otosclerosis, you can see all these. Okay, sensory neural hearing loss, the most common type, presbycusis, old hearing, noise-induced hearing loss, medications, ototoxic drugs, or ototoxic exposures in the plant, solvents, heavy metals like lead or mercury. Meniere's disease is sensory neural because it's a hydrops or swelling of the cochlea. All right, sudden sensory neural hearing loss is also similar. Cochlear pathology. Acoustic neuroma is a tumor of the eighth nerve. So all these you can't see with your otoscope. And certainly hereditary prenatal issues. Most of these causes sensory neural are permanent and not treatable. And of course, we have mixed type loss, which we see all the time, both sensory neural and conductive. So you may see somebody with noise-induced hearing loss with wax in their ears. So again, they're going to have patterns that look very, very similar. You'll also see mixed sensory neural, where you see noise and you see presbycusis, somebody's gotten older, on top of noise-induced hearing loss. Very, very common mixed pattern to see. Transient dysfunction occurs after a tendance to noise and maybe a temporary threshold shift, not permanent. Okay, so let's summarize. Characteristics of audiograms, and then we'll look at some pictures. Normal, unilateral loss. Now, unilateral loss is a red flag. Why? Because most industrial hearing loss is bilateral. So if you have a unilateral loss, statistically, it means something medically is going on in one ear that's not going on in the other. And what could it be? A tumor? Could be any kind of disease, right? Unilateral, but it's a red flag to think referral, to think workup. Now, you could have acoustic trauma on one side, like an explosion that would cause a noise-induced hearing loss on much more on one side than the other. But if it's truly unilateral, we worry. Flat audiogram usually indicates conductive. We don't know that till we order a bone and ear study. People often, when they're faking their audiogram, they often have a pretty flat pattern. Downsloping configurations are classic for noise-induced hearing loss and presbycusis. And oftentimes they look very similar. Rising configuration is typical of Meniere's disease. Low frequency sensory neural hearing loss usually rises. And a 4K notch obviously is suggestive of noise-induced hearing loss, U-shaped, sometimes congenital rubella and other congenital diseases. Okay, so a normal audiogram shows left X, O right, and is 0 to 25 in all frequencies, which we're seeing here. And you see the bone conduction indicated by these brackets where there's masking usually. Okay, so what's this? This is noise-induced hearing loss. It's early on the left side. And then as the years progress and the person doesn't wear their hearing protection, it gets worse and worse and worse. And you get more and more of a notch. A lot of times when I visit all our plants and I travel from site to site, people say, well, I don't know, it just steeply goes down on both sides. Well, how old is this? Oh, well, he's early 60s. Oh, well. So now you got presbycusis on top of noise-induced hearing loss, and it knocks off that recovery, and it's hard to tell what it is. So you have to look at the prior audiograms, and oh, there's the notch. Oh, yeah. Notch, 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 bigger, bigger, bigger. And now older, 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 and now I don't see as much recovery. So this is noise-induced hearing loss and presbycusis as they get older. Okay. So this is what presbycusis looks like, gradual sloping. It is bilateral because, again, you age in both ears, so it would be bilateral. Okay. This is the so-called air-bone gap. And what is that? Well, bone conduction is indicated in green. Okay. So the audiogram I did on my plant was the blue one on the left ear. Kind of a flattish pattern, some high frequency loss. Kind of flat though, doesn't look classic for noise-induced hearing loss. But when I send them out to get bone conduction study, the bone is normal. What's that mean? Cochlea is normal. Eighth nerve is normal. This is conductive hearing loss because the air conduction is abnormal, but the bone conduction is normal. So this is a so-called air-bone gap that's classic for conductive hearing loss. So what could this be? I don't know. Look in the ear. Probably see something abnormal. Could be wax. You don't see anything at all and everything looks fine. Could be otosclerosis. Can't see that very much. So this is the so-called and famous air-bone gap. Okay. Another thing to consider, here's unilateral hearing loss. Okay. The blue is left. The red is right. So this guy's got flat pattern, a lot of loss on the right. Okay. And what happens is, as the audiogram machine gets louder and louder, it just blasts the ear trying to get the person to respond, to hit the trigger. And then finally, it conducts through the other side of the skull to the other ear and they click the button. So in unilateral hearing loss, if you don't use masking, you underreport the amount of loss in that ear. So now with masking, when you put sound, white noise, in the good ear so that they won't hit the trigger and you're just measuring the bad ear, now the true loss is on the right, green, not the bottom. That's the real hearing on that side. Okay, with masking. And that's the purpose of masking. Masking is used for unilateral hearing loss to make sure it doesn't underreport the degree. Okay, this is a classic Meniere's disease, rising slope. And of course, we know patients should have hearing loss, tinnitus, as well, and vertigo, the triad clinically. And of course, typical trough shape congenital type hearing loss, deafness. All right, let's talk about one of these disorders. And now we're going to move from sensory neuro into conductive causes. So let's talk about the conductive causes of hearing loss. So a cholesteatoma would be one. It starts with a hole in the tympanic membrane, often in the attic portion. Get water in the ear chronically, and you get an overgrowth of squamous epithelium from the canal growing through the hole, producing a mass of dead cells, basically. Squamous epithelium. So it grows through. It's not a malignancy, but it gradually gets larger and larger and destroys the ossicle. Okay? And so very, very important to recognize this and not send somebody out and tell them to just keep wearing their earplugs, because this is surgically correctable, as most conductive things are correctable surgically or medically. This is what it looks like through an otoscope. We always supposed to call it fish flesh because that's what it looks like. It's wet looking fish flesh, smells. Squamous epithelium in the middle of the ear can be congenital or acquired. It's a result of retraction or usually perforation of the TM. The signs and symptoms, you don't usually get pain, but they get fullness. And they have a chronic draining ear, painless otorrhea, middle ear depression, and it's a conductive hearing loss. So you get the air bone gap. Treatment is surgical resection, tympanoplasty. So it's conductive and it's unilateral. It's almost always unilateral. Okay, so now let's take another conductive cause that we can't see, and that's otosclerosis. Otosclerosis is a fixation of the foot plate of the stapes as bony sclerosis. It gets fixed and doesn't move. Well, if the thing doesn't move, it doesn't transmit sound into the cochlea. So it's unilateral, but you can't see it. But if you've ruled everything else out, can't see anything else, and it's a classic pattern, you may have made the diagnosis or pretty strongly confirmed. You may not be able to see it, but it's probably there with a normal ear exam and a big bone ear gap. Okay, usually it's conductive. It is conductive hearing loss progressively from the low frequencies to the high, usually flat pattern, okay, and begins unilaterally. It can sometimes progress to bilateral loss. You may get it on both sides. If you're ever on Jeopardy and they ask you, well, what is this thing here? You look at it and you say, well, up at the top here, you see bone conduction. Looks fine. The bone, so the cochlea is hearing fine. The eighth nerve is working. Okay. But air conduction is terrible. Look at that. 250 Gs, 70 dB loss. And it looks kind of like a mountain, but that's a huge bone air gap. And that is called a Carhart notch, which is classic for otosclerosis. Probably an ENT otology board question. Or it's this little mountain configuration of Carhart notch. Here's the treatment for it is a stapedectomy, basically a mechanical plunger that allows the stapes to move again, vibrate. And then we move on to presbycusis or older hearing. Now here's a little bit of controversy. Almost everybody loses their high frequency hearing as they get older. And the older you get, the more you tend to lose. Great. Okay, and it kind of looks like noise-induced hearing loss, but it doesn't have that 8,000 recovery. Okay, so here's men and women. Unfortunately, when OSHA established these tables, it was only a few hundred people. And no one was greater than the age of 60. Well, I don't know about your plants, but in mine, there's a lot of people greater than the age of 60 working. And if we don't have any way to correct them greater than the age of 60 for presbycusis, it's kind of a problem. We have to keep using the age 60 over and over. So I wrote to OSHA about this, and it got published and said, hey, why don't we use NHANES? NHANES is a massive study, thousands and thousands of people, much stronger power to the study, and it goes to a much older age. OSHA wrote back and they said, okay, you can use either the OSHA tables or NHANES, whichever one you want to use. But if you're going to start with one, then use it all the way through. We don't want you to switch back and forth. But if you want to start with NHANES for a new plant and use that, fine by us. And that's what they put in their field manual and the letter back to me. Okay, let's keep going. This is sudden sensory neural hearing loss, and I see a number of these cases. People come in and say, Doc, I can't hear anything. I woke up this morning and I can't hear anything out of my ear. What the heck is wrong with it? And once I hear that, that's sudden. Now, I don't know whether it's sudden sensory neural because I can't do bone conduction in most of my plants. But when I see that flat pattern, I'm like, uh-oh, that is not noise-induced hearing loss, and it's sudden onset. So you can see in this complete audiogram here that in the other ear, the right ear on the top, everything's fine. But look what happened to the left ear suddenly. Bone and air conduction are tracking together. So what does that mean? That's sensory neural. So where's the lesion? The lesion's in the cochlea. Okay? Because that's what causes sudden sensory neural hearing loss. It's a disease of the cochlea. Now, over time, most of these people get better. And this is the same audiogram, A and B. Patient A became patient B as time got better and he became healed. C shows the same thing. Here's the patient, and you can see the right ear is on the right, up top fine, but the left ear showing sudden loss of low and mid frequencies. Over time, this person got better. Now, it's kind of important to recognize this condition. Doesn't look anything like noise-induced hearing loss. It nearly always occurs over less than a 72-hour period. Recovery is often spontaneous, so many people, by the time they get an appointment with ENT, it's all better, okay? But some people don't get better. They get permanent hearing loss from this. 90% of people report tinnitus, and about up to half people have vertigo with this too. It often occurs on awakening. The NICDC definition is 30 decibel loss in at least 3 test frequencies over a 72-hour period. Most is unilateral. 3% is bilateral. What causes it? We don't know. But it's thought to be a viral cochleitis, microvascular event, autoimmune disorders may cause it, prothrombotic states, and also herpes simplex type 1. One of the reasons it's important to recognize this is to make sure you call ENT and ask them what they want you to do, or send the patient right there to be seen. Because oftentimes they may inject through the tympanic membrane steroids and put the patient on antivirals. It's controversial whether these are effective or not, but for the standpoint of liability, this is something that, needs sort of urgent treatment and protects your liability. So definitely you want to get right on it and refer it. Or at least call them up and say, okay, what do you want me to do? You want me to start them on steroids? This is the pattern. You can send the audiogram to them. Okay, a neuroma. Here's what it is, a tumor of the 8th nerve. That's what it looks like. Not much room to expand. It starts pressing on the facial nerve. As it expands, it causes a loss of corneal reflex on the same side because it's hitting the facial nerve. That's pretty late sign. Earlier sign is on a complete audiogram, speech discrimination is low because the tumor distorts the sounds. It's destructive to the 8th nerve. So not only you get decreased hearing, but you also it changes the character of the sounds. So low speech discrimination on an audiogram is sort of classic sign, especially less than 80 degrees, 80%, sorry. All right, this is what it looks like on CT, or this is the gadolinium MRI. That's a pretty big one. Unilateral, usually it's the high frequencies that decline first, and it's progressive. It's unilateral and it's progressive. Every year it gets worse and worse on one side. It's rare and it's progressive. You may lose the corneal reflex as it gets more severe and expand. You may get a positive Romberg on that side. Diagnosis, of course, by MRI. Okay, Meniere's disease. The triad, hearing loss, low frequency, tinnitus, and vertigo. Here's what causes it. Swelling of the cochlea and the semicircular canals. Probably on an autoimmune basis. Drainage system is blocked, and it causes fluctuating pressure of the fluid in the inner ear. What does it look like? Classic. Sensory neural, bone tracks air conduction, low frequency. It's a so-called ascending pattern. But again, you got the classic tinnitus going on with it, recurring episodes of tinnitus and vertigo with it, which is a dead giveaway. Okay, here we got noise-induced hearing loss bilaterally. Here we got presbycusis, of course. And what do we have here? Here we have another bone-air gap, okay? A bone-air gap. So that's bone conduction on the top, air conduction on the bottom. Flat pattern, not noise-induced hearing loss. What could it be? What would cause this? Well, look in the ear. Got wax in the ear? Could do it. No wax in the ear? Everything looks fine? Maybe otosclerosis. Unless the person, like several people that I've seen, had a motorcycle accident and whacked their head on the pavement. And then what could it be? When there's a history of trauma, it could be an ossicular chain disruption. Those ossicles get disrupted or dislocated, that's conductive. And I've had 2 or 3 of those from traumatic accidents. So there's your bone air gap again, normal bone conduction, abnormal air conduction, flat pattern. Okay, this is, of course, upsloping, which is typical Meniere. So let's look at some more audiograms that come from our clinics. This is a classic pattern, mixed pattern that we see all the time. And it really is largely noise-induced hearing loss focused around 4,000. But because the person's older, they also have superimposed presbycusis so that you don't see as much recovery. Although if you go back and look at the older audiograms, you'll see lots of recovery, especially when they're younger. Certainly the left side is more severe than the right. Why? I don't know, maybe he fires a rifle. Okay. Recreational rifle fire causes the blast, more exposure on the left side than the right for a right-handed shooter, and tends to produce this kind of a pattern. It's a very common pattern we see, mixed pattern. Here's another one, very similar. Nachi, noise-induced pattern without the recovery, but without the recovery, most likely older person, presbycusis, and noise-induced hearing loss. Here's one that's interesting. The right side is totally normal, as you can see, but the left side's notchy looking. Looks kind of like noise-induced hearing loss. There's where the history is so important. So, look in that left ear. Okay, don't see anything. What's this person do? This person was an ambulance driver and often drove with the left window down. So really had an acoustic pattern, acoustic trauma kind of pattern, noise-induced hearing loss on the left side and the right. That's the one exception to bilateral industrial hearing loss being bilateral, is if you got a loud machine on one side of you, it may look very asymmetrical. And so if you're working on an assembly line or something like that, which side is a loud machine on? You always want to ask the person. And but certainly EMS drivers and people like that can have an audiogram like that. This next case is hereditary deafness, not noise-induced hearing loss, of course. And here's another one of those that kind of looks like several things going on. It looks like on the left, kind of a noise-induced hearing loss pattern with recovery, depending on the age. Yeah. But on the right side, it looks like something totally different is going on. So again, there doesn't have to be just one disease of the ear. There may be more than one disease. There may be 2 or 3. But it looks very suspicious for a conductive pattern on the right side. This person really needs a workup. Okay, now let's switch gears and talk about the hearing conservation standard. Noise exposure limits, exposure monitoring, we know all this stuff, right? Hearing protection, all that, record keeping. Okay. What does OSHA say? OSHA says that the current audiogram must be compared to the baseline audiogram. A technician can pour the comparison, but all problem audiograms must be reviewed. And the review must be performed by an audiologist, otolaryngologist, or physician. Key points. Okay. Now, I don't know about you, but we don't employ any ENTs, or we do have some audiologists. Mostly what we have is physicians and nurse practitioners and PAs. So can a nurse practitioner or PA render an interpretation and put it on the OSHA log or not record it? No, according to OSHA. Must be a physician or audiologist. No, they can't. We've asked them many times about that. So, well, they work for the physician. They may have a lot more knowledge than our collaborating physician. Can't they? No, can't do it. But they can work the patient up. They can chart on the patient. They can make a recommendation, the chart. You can get industrial hygiene and safety to see if there's noise exposure. So you can certainly get their input. You can use the CAT trained RN because they're some of our most skilled in this whole field. Definitely can use them. They can't make the final decision, but certainly they're all involved in helping to make the final decision as a team. We have tried different approaches to this. Many times we have a collaborating physician in the community for the nurse practitioner PA on site. So we'll have the collaborating physician sign out the final interpretation that is done by the RN and NP PAs. But the collaborating physician has to have training in this area. In its complex area of occupational medicine. The highest level of training now is the professional supervisor from CAT. And that's what we're getting most of our physicians who are interpreting a lot of these. We're lining them up into the professional supervisor course from CAT. And that's a great course. Takes 2 days. There's a test, but very, very good course. One of the problems with physicians interpreting audiograms at distance, they can't see what's in the air, but they can have the RN look or the NP or PA look. And so oftentimes we'll do that. But again, should be a physician making the final decision or an audiologist, although there's even some restrictions from audiologists. Okay, let's keep going. What's a problem audiogram? OSHA says all problem audiograms have to be reviewed by physician, otolaryngologist, or audiologist. So what is one? Well, an invalid audiogram, one that doesn't look right, doesn't look like the test was done right, is a problem audiogram. That's got to be reviewed by a physician. One that's asymmetrical is a red flag because there may be a disease in one ear that needs treating. One that has an STS is a problem because what's the reason they have an STS? They're not wearing the hearing protection? That's a problem, even if it's temporary. An audiogram configuration like a flat pattern that's not consistent with noise exposure is a problem. That needs workup, referral. Unilateral hearing loss, we said, is a problem audiogram. Probably indicates a medical disease in one ear. Or a severe noise-induced hearing loss indicating a major effect on lifestyle or communication or safety concern is a problem. They need a hearing aid. They got noise-induced hearing loss. We know that. It's classic. But they got a lot of loss in the communication range. Therefore, they need a hearing aid. Therefore, they need a referral. This is an invalid audiogram, you see, where the audiogram, same numbers all the way across, which should never occur. And then you have one that's extremely abnormal. That's not physiologically possible. Or one frequency that says non-responsive. NR. That's certainly invalid. So invalid audiograms could be low frequency hearing loss, suggestive of test interference. Most test interference is low frequency from people walking by or telephones ringing or things like that near the booth. All numbers are the same. That suggests equipment malfunction. Number of frequency levels which are not consistent and not physiologically probable, we just saw. Non-repeatable or reproducible audiogram. You put the person in twice and you get two completely different answers. No, invalid. Something's wrong. Okay. Go in there and do the audiogram on yourself, or have the nurse do it on his or herself. Significant improvement in noise-induced hearing loss should not occur. It's permanent. If it occurs, it probably was not noise-induced hearing loss. Maybe it's an allergy. Frequencies that are missing and no response. So invalid audiogram needs to be repeated. And we have to check the equipment. Okay. Now, standard threshold shift. Worsening hearing by 10 dB, right? OSHA defines an STS as 10 dB shift from baseline 2, 3, and 4 in either ear. And you may correct for aging. Okay, so there's a threshold shift. We're not going to belabor this or get into the details, but it's greater than 11. We would also employ presbycusis correction and C. But that's what we're looking for. That's a classic noise-induced pattern. Average difference between baseline and annual, add to 3, divide by 3. Greater than 10, you have an STS. Okay. Presbycusis correction is allowed. And whether you use OSHA tables, which these are, pretty old, or whether you use NHANES, it's up to you, as long as you're consistent through the years, says OSHA. But that's the tables. And this is computer interpretation, of course, which showing you that current is being compared with baseline. You see the actual shift, and then you see the corrected shift, where the computer is corrected. And again, if you're not over 10 dB, well, corrected, then you don't have an STS if you're using correction. Some states don't allow it. Okay. And what else do we need to do? We got to give the person a letter within 21 days if they have an STS. It explains that they have had a STS and what that is. We need to retest them, both ears, 30 days after the annual test. And you don't have to retest them within 30 days, but you don't retest them in 30 days, then you have to live with the original result if it shows an STS and record it if you don't. But if you retest them in 30 days and they don't have a confirmed shift, then you don't have to OSHA record them. You can say, well, that was a temporary shift, not a permanent shift. So the retest is only required if the test is invalid. Then you have to retest them. And at this point, the next step is, of course, determine if it's work-related, if you have an STS. So what are the follow-up procedures? Well, employees not using hearing protectors must be fitted with them and trained to use them. Employees already using them must be refitted and retrained. And this is what a lot of medical providers forget to do. Oh, well, see you later. Okay, yeah, an STS. Well, no. Give them the protection and watch them put them in, because most people don't put them in correctly. They don't screw them in tight enough. They don't know how to retract their canal. And don't forget that once they have an SDS, their exposure limit is now 85 dB, not 90, according to the OSHA regulation. So, and if they need a workup to rule out a medical condition, to rule in or rule out, OSHA says the employer must bear that expense. Okay, we revised the baseline. Okay, now this has undergone some change and recommendation, but basically you may substitute an annual audiogram for the baseline when the reviewing professional supervisor determines that the STS is persistent. Persistent. What's that mean? 30 days? Yeah, it's confirmed in 30 days. Is that persistent? Is that persistent? OSHA doesn't say what's persistent, but audiologists say what's persistent. In their mind, 6 months is persistent. But we don't test people at 6 months. We test them on a yearly basis. Therefore, we would not revise the baseline until the following year if the test is confirmed. If it's not confirmed, and they're already recorded on the log, we'd redline the log. So when the baseline is revised, this test becomes the test you will compare all future tests to. Each OSHA advises that each ear has to be considered separately. Okay. And the baseline revision should be revised towards the more sensitive or least abnormal audiogram of the two that you do. Okay, I'm not going to get into too much of this. You know about engineering controls, administrative controls, PPD. And of course, we use the managing noise exposure hierarchy controls. You've seen this many times. Eliminate the noise, substitute it, get another machine, engineering controls, administrative, and PPE is the least effective. This is a real problem here, is that people don't wear their hearing protection, and they get SDSs because it's in, but it's not in tight enough. So I always open my drawer, give them the protection, put that in, and then I go over and inspect them. And many times it's not in tight enough. So I pull the air up, I crank it in there, and they go, "Whoa, that's really tight, doctor." I said, "Yeah." "What? What'd you say?" "Yep, that's right. Because when you chew gum or you talk to your coworkers, it loosens the plug. And those plugs have to be tightened up about every hour. Very important to do that. If they're not tightened up, they don't work very well. Okay, now what about recording? What does OSHA say about recording? OSHA says, has the employee suffered an SDS, which is 10 dB, average 2, 3, and 4, in one or both ears? The answer is no. Then it's not, doesn't belong in the OSHA law. Okay, but if yes, you go on to the next step. And the next step is, well, okay, they had an SDS, but was it an abnormal audiogram? Were you above 25 dB from audiometric 0 for those three frequencies? 2, 3, and 4? If so, then you meet. If no, then again, you could have an SDS, but you're not recordable because you're not over the 25 dB from audiometric 0. But if you meet both those criteria, the third one, which is the hardest one, is it work-related? And OSHA has some advice about how to determine that. If it is, it goes on the OSHA log and you check the hearing loss column. Okay, so what's the criteria for determining work relationship, work relatedness? Well, ACOM says occupational hearing loss does not progress once the subject is removed from noisy environment. Right. They have to have a significant exposure to hazardous noise. And you'd be surprised all the people I've looked at their audiograms. And then I said, well, what's this guy do? Oh, geez, I don't know. Let me check. Oh, he's an accountant. Well, I'm not putting him on the OSHA log unless, as an accountant, what's he got? His stereo turned up real loud? You always have to make sure person exposed to hazardous noise. Gradual onset hearing is symmetrical or nearly symmetrical. 4,000 notch. Rate of loss is greater in the first 10 to 15 years, decreases as time goes on. In contrast to age-related loss, presbycusis, which accelerates over time, speech discrimination scores are not generally severely affected, like a neuroma would be. A neuroma definitely affects your speech discrimination. Okay, generally not more than 40 dB loss in speech frequency, 75 on high frequencies. Okay, so let's summarize the final rule. What does it say? Okay, you look for an SDS. You can perform a retest in 30 days. If it drops out, you don't have to record it. But if it's confirmed, it's got in 30 days, it's got to go on the log within 7 days, as all entries analysts do, 7 days. So that means 37 days. Again, it has to be work-related. You don't put non-work-related SDSs on the log. Okay. Now, the last two bullets. Last three bullets are just really important. This is OSHA speaking. Work-relatedness must be determined. If an event or exposure in the workplace caused or contributed to a shift in hearing or significantly aggravated a previously existing hearing loss, then it's recordable. That's what OSHA says. So it doesn't have to be the whole cause of the hearing loss. It can be just an aggravation. Work-relatedness, OSHA goes on to say, is presumed if the audiogram shows noise-induced hearing loss and the employee works exposed to hazardous noise or in a hearing conservation area. So that's the presumption directive from OSHA. And that's what they say. Well, we're assuming if it quacks like a duck and looks like a duck and waddles like a duck, it's probably a duck. Now, it could be an ostrich, but it's probably a duck because do they work in a hearing conservation area? Yes, they do. Well, then it's up to you to prove it's Meniere's disease or otosclerosis. It doesn't look like noise-induced hearing loss, okay? But it's presumed that it's noise-related if it meets the criteria it's outlined by OSHA and they work in a hearing conservation area. Do I have to record the hearing loss if I'm going to retest the employee's hearing? Well, no, if you don't, first 30 days. And if the retest doesn't confirm it, then no, you don't have to. But if it confirms it 7 days and it's work-related, yeah, it goes on long. Although if it doesn't, it's not persistent next year or 6 months from now, you can redline it off the line. Say it's not persistent, so it's probably allergies or something else. Are there any special rules for determining whether a hearing loss case is work-related? No. If an event or exposure, again, caused or contributed to the hearing loss, significantly aggravated, you must consider the case to be work-related. This is an algorithm we follow at our sites. And it's kind of complex, but it really just shows that everybody gets a screening audiogram who works in a hearing conservation area. We don't do hearing tests on people who are not in hearing conservation areas unless they're exposed to solvents or other exposures that we suspect ototoxic things. But all problem audiograms are reviewed by the physician or audiologist. And then if they're normal, they're just reassured. If they're abnormal, they get an exam by the site physician, look in the ear. If the ear shows an abnormal exam, something we can fix, like wax in the ears, we'll clean them out. And then repeat the audiogram. If we don't know what's wrong or something that like a hole in the drum, they need a tympanoplasty, we'll refer them to ENT. But most people, will have a normal otologic exam and they have abnormal audiogram. So then we need to make a decision, well, does it look like classic noise-induced hearing loss? If so, then we just go on. If not, we may need bone and air conduction, complete audiogram, speech to scrim, and tympanometry, or we just send them to ENT, either way. And at that point, we got to make a decision whether to OSHA record them, report to safety, and so on. And file workers' compensation in some cases. Occupational hearing loss, the criteria we use: permanent threshold shift, bilateral, I'm at the top here, positive noise exposure history, hearing. Oftentimes this isn't real critical, but if they always wore their hearing protection, then how do they get it at work? Classic noise-induced pattern, medical causes ruled out, STS occurs during the time of exposure, not when they had an office job, and rule out recreational causes. That's kind of our checklist for how we work these cases up. Okay. So summarize the final rule. 30 days, gonna repeat the test, record within 7 days. That's 30 days, 7 days from the initial test. Work-relatedness significantly aggravated, doesn't have to be the old cause. And it's got, you want results of subsequent testing. If later testing performed as part of the hearing conservation program, and down here indicates that the STS is not persistent, then the employer can line out the entry. Okay, good. All right, what's the role of the professional supervisor according to ACOM? Well, supervision of audiometric testing. Follow-up of employees with hearing loss, making sure whatever is causing the hearing loss, they're getting appropriate treatment if they need it, and retraining, refitting. Baseline decisions like revising baselines, decision on whether to use age correction and whether you're going to use OSHA tables or NHANES, determination of work-relatedness, follow-up on problem audiograms, and delegation to other qualified providers. We're a team. We work together. Physician may make the final decision, but we work the patient up as a team. Who can determine work-relatedness? Well, lots of people can. They can contribute. Industrial hygiene and safety can because they're doing the monitoring. So we want to make sure they're in hearing conservation area, noise exposure. We also would depend on them for ototoxin exposure. You know, they exposed to metals or, you know, solvents and at what level? 50% of the PEL? That may be significant. We have input from the physician, audiologist, nurse practitioner, physician assistant, everyone. Any of these people can have input into the case and charts on the case, including the OHNs and COHNs. Experience and document and reviewing audiograms. So everybody, it's a team effort, but we are very careful to make sure that the physician signs off that makes the final decision. Can we use an industrial audiologist? Sure. Yeah, that works too. But one of the issues we've had, if we just use RNs, is that we find the RNs will work beyond their scope of practice as an RN because it's a very complex area. And they're making medical decisions about work relationship, about, you know, the cause and things like that that involves medical decision making. So we want them to turf it up to the NP, who certainly can make the scope of practice go a lot further, and then up to the physician. Okay, let's go on. Determining OSHA recordability. A PLHCP can determine that a hearing loss is work-related and meets OSHA recordability criteria. However, this is OSHA speaking again, only a physician can determine that a hearing loss should not be recorded on the OSHA log. I'll repeat that. Only a physician can determine that the hearing loss case should not be recorded on the OSHA log. Not even an audiologist. And the audiologists weren't too happy about this, but that's what it said. And that was a letter of interpretation in 2007. So we see a lot of conditions that are now work-related. Things that are highly asymmetrical or unilateral, flat patterns, configurations not typical of noise-induced hearing loss, and lots of evidence of other ear medical conditions like otosclerosis, ototoxicity, Meniere's, sudden sensory and hearing loss, and we've detected a number of neuromas. Issues, what are they? One issue is cross-contamination in the booth, and that's been a challenge, especially during COVID. You know, we have people going in and out of that booth, breathing the same air, not a good situation. So we really had to clean the booth after every time you use it and let it air out and use a special HEPA filter, you know, for the booth. So there's concerns about that, but that is doable. One of the problems is these air purifiers make a lot of noise and they can interfere with the test too. We don't keep them in the booth, but even outside. Then the other controversy, of course, we already said, presbycusis correction. You use OSHA tables or NHANES or both. Who's best suited to make the decision of work relationship? We talked about that. And, you know, again, it's scope of practice concern for the RNs. They can certainly contribute, but, you know, can an MPPA? Yes, they can, but can't make the final decision in our estimation. Having the noise monitoring data is very important because if you're at a distance 2 states away and you're interpreting these tests and you can't see what's inside the person's ear and you're not doing an exam, you got to depend on somebody else for that. And you don't have you may not have the monitoring data. And that's one of the problems with referring people out in the community to ENT or audiology. They don't have it either. Okay. What's the problem? Audiogram, unilateral, asymmetrical, low frequency hearing loss, flat pattern, descending pattern, all that stuff. Even an STS, invalid audiogram, or an audiogram that's getting worse. What about this boothless technology? Well, it's pretty cool. And in the professional supervisor course, they discuss this quite a bit. OSHA seems to be okay with it. The issue is that the newer cupped headphones that the boothless uses can attenuate the outside noise very significantly. Comparable to booth, it's equivalent to a booth. It's like you're wearing a booth on your head. Okay, it's calibrated. And sites that seek boothless technology often want to avoid buying a booth because they don't have the space for it, or the cost, too expensive, or both. And they also want, if your plant's, you're an auto company, you got 8 different manufacturing buildings in the same complex, you don't have to send people to one location. You'd rather have the team rotate their test location. So that's an advantage of using boothless. The headphones must attenuate to OSHA standards at a minimum, but the ones we've looked at attenuate to ANSI standards, which are even more conservative. So they meet the OSHA standards and ANSI standards. But the site should find an acceptable quiet area to perform this kind of testing, usually like a very quiet, empty office. Medical centers are usually too noisy, we find. Phones ringing, people walking by, noisy machines running in the plant, too noisy and not really quiet enough. Use a sound level meter to ensure that you got quiet location to do the testing. Now you're gonna have lots of, they're basically in a booth when they got the headphones on. But again, you're not gonna put your audio booth in a noisy area anyway. You want to ensure kind of a quiet area. You want to keep the monitoring sound level information for future documentation as these cases go to a workers' comp court, because those questions are going to be asked. What were the conditions for testing? Some of the devices will pause or stop the test if the level outside or inside the headphones especially exceeds the OSHA standard. It just shuts down the test. And that's called real-time testing. So the machines can do that. And that real time is great because we know it's not going to collect bad data. It has to be in compliance in order to collect the information. It'll just shut down and it'll restart when the level is within OSHA and ANSI standards. Fit testing is being used more and more. It's great, wonderful. That way you can really assure that the person's putting it in correctly and they're really protected as best practice. And many of these models with boothless can do multiple employee testing at the same time, which is another advantage. Okay, we talked about fit testing. Other potential issues for reviewers looking at audiograms, you got to make sure you review the hearing history too. That's part of getting a diagnosis. You got to have the hearing history. Who's performing the otoscopy? Is it the nurse? If you're not there, you're not looking at the patient. And professional supervisors, do they have access to the noise monitoring data, which is kind of important. And you may not have any provider assessing each individual, at a distance, especially looking in their ears. The other concern we've had is that these people are all filling out an audiometric history, and a lot of times they put things like their blood pressure or their cardiac conditions, a lot of other things in these good questionnaires. That's not something we want to share with the client because it's got PHI information, so we have to be very careful to avoid that. Let's say a word about ototoxicity. 22 million people are exposed to ototoxic chemicals every year, and 12 million with noise and ototoxic exposures. This comes right from Masterson's article, which is in this month's JOEM. NIOSH, OSHA, AIHA, ACGH, and ACOM all recognize ototoxic agents' contribution to hearing loss. Can easily be overlooked. ACGH recommends annual audiograms for workers if they're 20% or more of the TLV for a number of toxicants. And the U.S. Army is doing autograms on people 50% of the OEL. So what things are we concerned about in the literature? Solvents, toluene, xylene, trichloroethylene, styrene, carbon disulfide are the first ones described, but certainly can include categories like cleaners, thinners, paints, lacquers, glues, pesticides, anti-neoplastic drugs. Yeah, I have to see that a lot in the pharma industry. Engine exhaust, phototoxic, organic cyanides, and tobacco smoke. Metals like lead, organic tin, and also mercury. I forgot to put that on there. Asphyxiants. Secondhand smoke may have ototoxicity because of the exposure to carbon monoxide, toluene, p-xylene, and ethylbenzene. So again, check that article out. It's quite good that studied the prevalence. Here's my references. And let's look at some cases if we got a couple minutes to do that, and then we'll try and leave some time for questions. So this is an old version of, this may be going back decades, but we love these slides because they're so cute in terms of the little pictures. This is an old OHM. We just sort of kept these slides the way they were because they really demonstrate a lot of good points. Okay, so when you look at this audiogram, you see this person, okay? And you say, wow, the right side looks fine. The left side, wow, looks like high frequency hearing loss with a notch at 4 to 6K with a little bit of recovery. Looks like noise on the left, but not on the right. What? Uh-oh. Well, gosh, that's not good because that's kind of a red flag, right? It is a red flag because it's unilateral. And what's the rule on unilateral? If it's unilateral, it's probably a referral or a workup. It's not classic noise-induced hearing loss, right? What the heck happened here? So let's keep going. So that's what the audiogram looks like. And you might say, well, maybe the guy worked on the line as a real noisy machine on the left, but he should have some loss on the right, if that's the case. You'd really want to work this person out, you know, see what's going on. But anyway, so you start doing the calculations, you correct, you subtract the current from baseline, you know, 2, 3, and 4, so you can start to see how the computer's doing this. Here's your baseline test. Here's your current. So 2, 3, and 4, you do your subtraction, 25, 20, and 15, and you average 20. Wow, you got a hit on that side. Now what about the other side? Well, let's see the right side. Okay. So we do the same thing. Nothing much on that. Okay. So on the 10 dB shift on the left, yes, it's shifting on the left. And is it greater than 25 dB average? Well, 40, 45, 55, yep, sure is greater. So it meets 2 out of 3 criteria. Next question is, well, is it work-related? Well, I don't think so because it's unilateral. And that's not typical in noise-induced hearing loss. So the computer says that a medical referral is indicated because, why? Because it's unilateral, okay? And that means trouble. There's something going on in one ear, it's not going on in the other. And the test shows asymmetry. So let's go on. Here we go again. Now what do? We repeat again, so the same thing, and there we go. Okay. So on the left side, we're shifting again. We've confirmed the shift on that side and nothing on the right. So we got the same thing, 10 dB shift, 10 dB shift with 25 dB average. But at this point, we can't say it's work-related unless we have something very incriminating in the workplace. And even then, I would probably want to work this patient out, make sure they don't have a neuroma or something on that side. So medical referral, yes. Test shows asymmetry. These are all things the computer is advising us on. So now we could revise the baseline, but we're probably not going to do that until next year, following best practices. Okay, so then if you were to say that it's work-related, well, then you can start saying, okay, it may be recordable, and again, you're going to reset the baseline. Let's look at another case. This is a case, this looks more typical in noise-induced hearing loss here. Classic look on both sides. Okay, let's do the math. Oh yeah, we got a shift on left side on this one too, not on the right. So we got a left, we are greater than 25 dB criteria. Yes, I think so. Okay, let's see. I think I went too fast. Okay, so is medical referral indicated? Why does the computer say medical referral is indicated? There's no asymmetry. What's the computer worried about? Well, look at the amount of loss in the speech frequencies, 2, 3, and 4. You got 35, 40, and 50. He's going to have trouble talking to his grandkids, right? And it's bilateral. He can't hear on one side and he can't hear on the other. So you're not referring really because it's any mystery to what the diagnosis is. You're referring because he needs a hearing aid. Okay. So, yeah. Okay. What about this patient here? I'm going to stop with this. And this is a young woman that came in, and there's her baseline. It was her audiogram has been normal every year. And then all of a sudden, this is her audiogram. And I said to the nurse, "Are you sure this is right?" She said, "Yeah, I did an audiogram myself, and I got the same thing that I always get when I did biology. I put Oscar in there, all that. The thing's working perfect." And so I started talking to her, and the first suspicion I had is I was using my normal conversation voice, and she was responding to me. So, is there a shift? Yes, there is. Is it greater than 25 dB? Yes. Is it bilateral? Yes. So you got 2 out of 3 OSHA criteria, but is it noise induced? Is it work related? I don't think it's work related. No, I don't think it's noise induced hearing loss. So what is it? Well, now you need a clinical assessment. So I just kept lowering my voice and talking to her, and she just kept responding. Finally, I knocked a book on the floor and asked her to pick it up. So I just whispered. She picked it right up. I said, "Okay, you faked the audiogram, right?" She said, "Yeah." I said, "Why did you do that?" She said, "Because I hate my supervisor and I hate this company." And I said, "Well," and I wanted to get workers' compensation like my friends who are retiring. I said, "Well," and this is a malingering audiogram. So when this happens, I think the key is to do a clinical assessment of the patient, lower your voice, and check them out because a clinical assessment, and then confront the patient. But before you confront the patient, make sure there's nothing wrong with the equipment because we've seen a lot of equipment problems. So make sure absolutely that the test has been repeated and there's nothing wrong with the equipment before you confront the patient. And I'm going to stop there.
Thanks, Clark.
And, just see what questions we have.
Sure. So the first one is from Tim Paz, who's going to be, oh, wait, no, hold on. It disappeared. Okay, Tim Paz. He's going to be speaking tomorrow morning before lunch on respirator fit testing. So hopefully, if you're attending or you'll check him out. So
Okay.
he asked about earphones, earbuds, headphones. Given the widespread use of personal listening devices and earbuds, headphones, have you observed any data suggesting an increase in STSs within the younger population over the last 10 to 20 years? In other words, are we seeing signs of noise-induced hearing loss in younger workers?
Oh, absolutely. I don't know that I personally have data, but there's been a lot written about this. And a lot of younger people think if it's just louder in their headphones, then they won't hear the noise on the outside. And somehow that's protective. It's not, as we know. And yes, they definitely can get noise-induced hearing loss. We usually have our safety folks work with them on that and say no. And then usually we don't allow, we're very careful about sort of how much sound music that they can use. And we are very careful to explain to people that these earbuds and things like that are not ear protectors. And in fact, you may be very likely making the situation worse by trying to cover up the sound from the lawnmower with AC/DC. So not a good situation. Very good thought. But I don't have any personal data, but I think there's been a lot written about this in the audiologic literature. Mm.
So, Clark, speaking of AC/DC, I would tell you that Thunderstruck or Hell's Bells is far better than listening to a lawnmower, but that's just my personal opinion. Um, so,
Absolutely.
Daniel Edgar asked for a unilateral loss that you deem non-work related, and you suggest referral. Is that something the company should pay for, or is the referral telling the employee to see his own provider for follow-up?
Um,
Not work related.
Generally, if the case is obviously not work related to you, okay, then I think the person gets referred to their PCP or to ENT, depending on the relationship, ENT, because and then it gets paid for by their insurance. Now you could say, well, they got high deductible. What if they don't go? Well, if they don't go, you got to tell, hey, you may have a tumor, you may have something serious. We're really going to recommend, and they complain because the high deductible. Oh, geez, I got to go to ENT. Oh, geez. Well, okay, go see your primary care doctor. One of the issues we have with sending the primary care doctor, which I think is a good practice, but a lot of times the primary care doctor is not familiar with reading audiograms and doesn't understand, all the, and so that oftentimes they'll just say, yeah, okay, I don't really see what this is. You got some hearing loss. I guess you better see ENT. But yeah, I think pay for it on insurance. If you don't know whether it's work related or not, those are the ones OSHA says the company has to pay for. If you got elements of noise-induced hearing loss and it looks like it, but there's elements of some medical condition going too, then OSHA would say the company's got to pay for it and do a causal evaluation and have ENT, with the noise data and everything else, your input, make a determination. Is it work related or not? Or do they have two different conditions or three different conditions where one may be work related or not? So,
Okay. Well, thank you.
mhm.
Next question from Dr. Lerner. The 8/29/07 OSHA letter of interpretation says only a physician can make the final call of OSHA recordability.
Yeah,
That imply that a physician has the authority to not call an OSHA recordable on the basis of the age-corrected test not popping positive, or else
yes,
must record
yes.
regardless if the
Yeah, that's correct.
non-corrected popping
Because
positive.
again, they think the physician level of training, lots of people have SDSs with medical conditions, and they're not noise-induced hearing loss. Okay, you can have an SDS from otosclerosis, from a tumor, from lots of different things. So that's why they want the physician involved. Yeah, you met all the criteria, but it's not work related. But they want the physician to say, this is another medical diagnosis. This is not work related hearing loss. And even though you have an SDS that meets all the criteria, um, there's they want a physician opinion that if it's not going to be recorded. Now they've also said that if you're going to put it on the OSHA log, sure, let the audiologist tell you to put it on the OSHA log, no problem. But if you're not going to put it on when it meets OSHA criteria for recording, we want a physician involved to say it's something else.
Okay. Um, we only have a couple minutes. I'm just going to skip to uh, Carl's question. He just asked, time permitting, ask about tinnitus.
Um, what about it? It's a real problem. Oftentimes, the tinnitus is a lot worse problem than the hearing loss for these poor people, isn't it? It's a very debilitating condition, and it's very frustrating. It's hard to deal with people. We put people in the tinnitus clinics. We refer them down in New York City. We do lots of different things with them, but it is a significant issue because these people with bad tinnitus can have just terrible. They can get depressed. It just drives them crazy, and they can't get rid of it. A lot of the strategies we try and use is to have music playing at the house, but not loud, but just to have, sound machines when you're falling asleep at night. Turn the sound machine on, something pleasant. When you're going around the house, you have some music playing, not real loud, but just playing it different. And that tends to mask. A lot of people find after they use masking devices that they they figure out how to mask with things that are more pleasant themselves, using music during the day, but they use the maskers at night or use them, with sound machines at night in their bed. Yep.
And Hell's Bells, would you say that's probably pleasant?
Yeah, right. Low
Okay.
volume.
Well, it's 2:30. Dr. Lerner had one more question. Would a new diagnosis of hypertension between baseline and an STS suffice to deny recordability?
I don't think so.
Yeah, I don't
No,
know either.
no, I don't think
That's going to
so.
affect your hearing.
No, generally not. It's not specific. No, if it's meeting the criterion, lots of people have hypertension, but they also have noise-induced hearing loss, and so that by itself would not. No.
Okay. Well,
Okay.
listen, Clark, I really appreciate it. I hope this is really helpful for those of us who find reviewing audiograms challenging. And I just you made my life so much easier when I sat through this when I was starting out. So it's just thank you.
Sure. My pleasure, Jeff, and great to talk to all of you. Have a nice conference.